Hello and welcome. Today, we're going to embark on a complete journey through perioperative respiratory monitoring. Think of this as a masterclass, following our patient's story from the moment anesthesia is induced and their physiology changes, right through to the complex monitoring we do intraoperatively, and finally, navigating the critical challenges in the recovery room. We'll be covering exactly what to assess, how to monitor it, and why getting every single step right is absolutely fundamental to our patient's safety. Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. Thanks to your support, our channel has grown steadily. If you have any topics you'd like to see covered, please leave a comment and we'll actively consider your suggestions. Your input truly does help us shape our content, so please don't be shy. Right, let's get into our roadmap for today. We'll start at the very beginning with how anesthesia itself immediately impacts the lungs. From there, we'll move on to our lifeline, the breathing circuit. Then we'll take a deep dive into assessing oxygenation and evaluating ventilation. And to finish, we'll focus on that final crucial phase, navigating recovery and being ready for any complications that might arise. Okay, part 1, the foundational changes. You see, before we can monitor anything effectively, we first have to have a rock-solid understanding of how general anesthesia fundamentally alters lung physiology from the very first moment. And I'm not talking about complications here. These are the expected, predictable effects that set the stage for everything else we do. This is such a crucial point to internalize. Even the most perfectly executed, flawless anesthetic will have significant and predictable effects on breathing. These aren't surprises. They are the physiological shifts we absolutely anticipate. Knowing exactly what they are and why they happen is what allows us to be proactive and stay one step ahead of any potential problems rather than just reacting to them after the fact. So let's look at the immediate mechanical impact. When a patient is awake and upright, their diaphragm actively contracts downwards, the chest wall expands, everything's working as it should. But the moment we induce anesthesia, especially with the patient lying supine, we lose that diaphragmatic tone. The abdominal contents push the diaphragm upwards or cranially, the chest itself actually narrows a bit, and the immediate result is a really significant drop in functional residual capacity, our FRC. We're talking about a reduction of around half a liter in the average adult. And that drop in FRC, which is effectively our patient's oxygen reserve, it triggers a whole cascade of effects. It goes down by about 20%, which brings it dangerously close to the residual volume. This promotes the closure of small airways in the dependent parts of the lung. Now, when you combine that with the high concentrations of inspired oxygen we often use, you get absorption atelectasis, creating a true physiologic shunt. This, of course, worsens any ventilation perfusion mismatch. And as if that weren't enough, the total compliance of the respiratory system plummets and airway resistance generally goes up. These are the core physiological challenges we are actively managing from the word go. So, with those physiological challenges established, let's move to our first line of defense. The breathing circuit is our direct lifeline to the patient's airway. We have to be absolutely 100% certain of its integrity. It's fundamental. If the circuit isn't right, nothing else matters. So, it's a simple but absolutely vital question. How do we actually know that the tidal volume we've set on the ventilator is getting to the patient? We don't often measure the inspiratory volume right at the patient's mouth. Instead, we rely on a whole series of crucial indirect checks. We're watching the ventilator bellows move, we're monitoring our airway pressures, we're looking for chest rise and fall, and of course, we are glued to our capnograph and gas analyzer. All of these are essential proxies for confirming gas delivery. Now, disconnections are a critical can't-miss event. It's one of those things we all dread. As you can see in this diagram, there are several common failure points. This is why we have to be so systematic with our checks, starting from the endotracheal tube and its adapter, moving to the Y-piece, and checking all the way back to where the tubing connects to the machine itself. A failure at any one of these points means a complete loss of ventilation, and it's something our alarms and our own vigilance are designed to catch in a heartbeat. The flip side of that coin is an obstruction, which presents a different but equally urgent threat. A kinked endotracheal tube is the classic example we all think of, but we also have to consider things like mucus plugs, blood clots, or even a mechanical fault like a stuck expiratory valve. This is where monitoring our airway pressures becomes absolutely indispensable. A sudden, sharp spike in pressure is often our first and sometimes only warning of a life-threatening obstruction. Right, circuit secure. Now let's focus on the crucial outcome, patient oxygenation. Our goal isn't just to see a nice, reassuring number on a monitor. It's to confirm adequate oxygenation of the arterial blood and, critically, to ensure that oxygen is being delivered effectively right down to the tissues at the cellular level. And that requires a multifaceted approach.
Now, a crucial point here is that our target PaO2 isn't one single number. It's highly dependent on age. For most adults breathing room air, yes, we're aiming for 80 to 100 mmHg. But for newborns, you can see the target is much lower. And importantly, as our patients age, their baseline PaO2 gradually decreases due to age-related changes in closing capacity. This table gives you the key reference ranges, and that little formula at the bottom is actually a very handy tool for estimating what a reasonable PaO2 might be for an elderly patient. This table is brilliant because it shows the expected response to supplemental oxygen in a healthy lung. There's a really helpful rule of thumb here. For every 0.1 increase in the FiO2, the PaO2 should increase by roughly 50 millimeters of mercury. So if you're giving 40% oxygen, you'd expect a PaO2 somewhere in the ballpark of 200. If your patient's PaO2 is significantly lower than that, it's a clear signal that there's an underlying issue with gas exchange, most likely a shunt or a significant VQ mismatch. It is absolutely vital that we understand this distinction. It's a real trap for the unwary. Our standard pulse oximeter measures SaO2. That's the percentage of available hemoglobin that's carrying oxygen. But it completely ignores dysfunctional hemoglobins like carboxyhemoglobin in a heavy smoker. The true measure is the fractional oxyhemoglobin, or FOHB, which you can only get from a co-oximeter on a blood gas analyzer. This tells you the fraction of all hemoglobin that's carrying oxygen. You can see how a pulse oximeter could be dangerously misleading, showing 98% when the true oxygen carrying capacity is actually much, much lower. Ultimately, what really matters for the tissues is the total amount of oxygen carried in the blood, the arterial oxygen content, or CaO2. This equation shows us it's a function of three things: hemoglobin concentration, oxygen saturation, and, to a much smaller degree, the oxygen that's physically dissolved in the plasma. This just highlights why an anemic patient can be profoundly hypoxic at the tissue level, even with a PaO2 of 200 and a saturation of 100%. Without enough hemoglobin to carry it, the total oxygen content is just too low. The famous oxyhemoglobin dissociation curve. It beautifully illustrates the dynamic relationship between PaO2 and saturation. What's key here is understanding what shifts this curve. A right shift, caused by things like acidosis, a high CO2, or a fever, means hemoglobin gives up its oxygen more easily to the tissues. That's generally a good thing. A left shift, from things like alkalosis or hypothermia, means the hemoglobin holds on to oxygen much more tightly, which can actually impair oxygen unloading right where it's needed most. Pulse oximetry has absolutely revolutionized patient safety, but we must never ever forget its limitations. This list covers 10 common pitfalls. It's particularly important that we're all aware of the risk of occult hypoxemia in patients with darker skin pigmentation, where the device may overestimate the true saturation, low perfusion states, motion, IV dyes like methylene blue, and of course the dyshemoglobinemias we just discussed. They can all lead to inaccurate readings. The take-home message is always correlate the number on the screen with your clinical assessment of the patient. The AA gradient is such a powerful diagnostic tool. It sounds a bit complicated, but the concept is actually quite elegant. In simple terms, it's a measure of how efficiently oxygen is getting from the lungs into the blood. We calculate the ideal oxygen level in the alveoli, the PaO2, using that alveolar gas equation you see there. Then we compare it to the actual oxygen level we measure in the arterial blood, the PaO2. A big difference, a wide gradient, points directly to a problem like VQ mismatch or a shunt. While it does widen a bit with age, a large AA gradient is always a red flag. Okay, let's roll up our sleeves and actually walk through a calculation of the shunt fraction using the classic shunt equation. It looks a bit daunting, but let's break it down. We are basically comparing the oxygen content of blood from three different conceptual places: the ideal pulmonary capillary blood, CCO2, the actual arterial blood, CaO2, and the mixed venous blood, CVO2. The equation is essentially asking, how much did the arterial blood's oxygen content fall short of the ideal? So in this example, with a patient on 100% oxygen but a PaO2 of only 100, we follow the steps and we calculate a shunt fraction of 39%. That tells us that nearly 40% of this patient's cardiac output is completely bypassing ventilated lung tissue. That is a very, very significant shunt. For our most critically ill patients, during major cardiac surgery or a liver transplant, intermittent blood gas sampling might just not be enough to keep up. This is where continuous intravascular blood gas monitoring comes in, and it offers some huge advantages. As you can see, you get real-time data, which allows for trend analysis, not just snapshots. This means much earlier detection of problems. It also reduces blood loss from all that sampling, saves critical time waiting for lab results, and lowers infection risk. For the right patient, this technology can be a genuine game changer.
Right, let's switch gears. We've talked a lot about getting oxygen in. Now let's pivot to the other side of gas exchange, getting CO2 out. Here, our focus is on the effective elimination of carbon dioxide and, just as importantly, assessing the mechanical properties of the lungs, properties that are dramatically altered the moment we take over with positive pressure ventilation.
This diagram highlights a truly profound physiological shift. During normal, spontaneous breathing, our diaphragm contracts, creating negative intrapleural pressure. This not only sucks air into the lungs, but also helps pull venous blood back to the heart. When we start positive pressure ventilation, we completely reverse this dynamic. We are forcing gas in with positive pressure. This change from negative to positive intrathoracic pressure has major implications for hemodynamics, particularly by reducing venous return and increasing the afterload on the right ventricle. Our arterial PCO2 is the most direct and reliable indicator of adequate alveolar ventilation. It's as simple as that. If you see the PaCO2 starting to climb, it points to hypoventilation. This could be from reduced minute ventilation, increased dead space, an exhausted CO2 absorber, or a sudden surge in CO2 production, as we see in malignant hyperthermia. Conversely, a falling PaCO2 means hyperventilation. This table is an excellent differential diagnosis to run through in your head whenever you see that number change. Dead space ventilation. It's essentially wasted breath. It's the volume of gas that's moved in and out of the lungs, but doesn't take part in gas exchange. Unfortunately, as this table clearly shows, many factors that are just inherent to our practice, anesthesia itself, positive pressure ventilation, periods of hypotension, all tend to increase physiological dead space. This just makes our job of maintaining a normal CO2 that much more challenging, because a larger chunk of every breath becomes wasted.
The capnogram is so much more than just a number. Its shape gives us a wealth of real-time diagnostic information. We all know the normal, crisp square wave, but then we see these other fascinating patterns. There's the classic Carrere cleft, that little dip that shows a patient's own breathing effort against the ventilator, a rising baseline that isn't returning to zero, that's rebreathing, likely from an exhausted absorber. And of course, the iconic shark fin pattern, a clear, sloped upstroke that screams airway obstruction, like bronchospasm. This table just brilliantly illustrates how many different clinical events can cause a change in our end tidal CO2. An increase might just be simple hypoventilation, but it could also be a catastrophe like malignant hyperthermia or a CO2 embolism during laparoscopy. A sudden sharp drop should immediately make you think of a low cardiac output state, a massive pulmonary embolism, or, most commonly, a circuit disconnection. Your end tidal CO2 is your canary in the coal mine. Distinguishing between peak and plateau pressure is absolutely essential for safe mechanical ventilation. Think of it this way. Peak pressure is the total effort it takes to push air down a pipe and inflate a balloon at the end of it. It includes both resistance and compliance. But the plateau pressure, which we measure during a brief inspiratory pause when there's no gas flow, is just the pressure inside the inflated balloon. It isolates the compliance component and gives us a much better reflection of the true pressure being exerted on the alveoli, which is our best indicator for the risk of lung injury. And we can use these two pressures diagnostically to troubleshoot problems in real time. It's a beautifully simple algorithm. Let's say your high-pressure alarm goes off. First thing you do is an inspiratory hold. If the peak pressure has shot up but the plateau pressure is stable, the problem is increased airway resistance. Think a kinked tube, bronchospasm, or secretions. However, if both the peak and the plateau pressures have risen together, the problem is decreased compliance of the respiratory system. Think tension pneumothorax, pulmonary edema, or abdominal insufflation. It's a powerful diagnostic tool. Right, let's move into our final section, which covers what is often the most challenging and highest-risk phase of the whole anesthetic, ensuring a safe emergence and being prepared to manage post-operative respiratory complications. The operating theater might be a controlled environment, but the recovery room can be anything but. This is the final hurdle. In the post-anesthesia care unit, the PACU, respiratory depression is our primary concern. But it's crucial to remember that its causes are multifactorial. It's tempting to just blame the opioids, but that's often far too simplistic. As this table shows, we have to consider central drive depression from residual anesthetic agents, muscle weakness from incomplete neuromuscular blockade reversal, an increased work of breathing due to pain or atelectasis, and even metabolic factors like hypothermia. Any of these can contribute.
These 7 issues are really the most frequent challenges we face in the PACU. Simple airway obstruction from the tongue falling back is incredibly common. Hypoventilation and hypoxemia follow from all the causes we just discussed. Then we have the more acute, dramatic events like laryngospasm and bronchospasm. And we must also be vigilant for the risk of aspiration and that fascinating phenomenon of negative pressure pulmonary edema, which can happen when a patient bites down on the tube and takes a huge inspiratory effort against a closed glottis.
So before we even think about removing that endotracheal tube, we have to be confident the patient has enough ventilatory reserve to manage on their own. This means assessing a few key parameters. We're looking for a spontaneous tidal volume of at least 5 milliliters per kilogram. We want to see a forced vital capacity greater than 10 to 15 milliliters per kilogram, and crucially, we need a negative inspiratory force, or NIF, that is more negative than negative 22, negative 30 centimeters of water. These are really strong indicators that they're ready to fly solo.
And beyond just the mechanics of breathing, we have to be absolutely certain of adequate reversal from any neuromuscular blockade. This is where clinical assessment is king. The ability to sustain a head lift for a full 5 seconds is a very reliable clinical sign that the pharyngeal and respiratory muscles have recovered sufficiently to protect the airway. A sustained strong hand grip and the ability to protrude the tongue against resistance are also excellent, simple bedside tests of adequate muscle function. So to conclude, we've journeyed all the way from the fundamental physiological changes of anesthesia, through all the intricacies of advanced monitoring, and finally to ensuring a safe recovery. The future, undoubtedly, lies not just in collecting more and more data points, but in intelligently synthesizing this wealth of information. The real challenge for all of us, moving forward, is to use this data to move beyond one-size-fits-all protocols and toward ventilation and recovery strategies that are truly tailored to the unique physiology of the individual patient in front of us. Thank you very much for joining this masterclass.